The first question. A patient comes with silvery white scaly erythematous blocks over extensor aspect. On examination, pitting of the nails was observed and there is involvement of the scalp. So what is the most likely diagnosis? And if you have marked the answer as psoriasis vulgaris, you are absolutely right. Psoriasis vulgaris is also called as chronic plaque psoriasis. So that is the other name. Vulgaris, remember, vulgaris, wherever it is there, it simply means that it is a most common manifestation of that particular condition. So you can see other options. Pemphigus vulgaris, it is a vesiculobullous disorder. Vesiculobullous disorder where intraepidermal flaccid bullae are seen. Intraepidermal flaccid bullae are seen in pemphigus vulgaris. Ichthyosis vulgaris, it is a condition where there is going to be a defect in the filaggrin, which is a filament aggregating protein, and because of which there is going to be skin manifestation in the form of fish-like scales over the extremities. And option A, lichen planus, we are going to see the manifestations in upcoming slides, so I'm not discussing about it here. In the image you can see that there are erythematous blocks which are surmounted by silvery white scales over the extensor aspect. So in this image you can see that the nail plate is having some depression. These are called as, very important, nail pitting, which is the most common feature of nail psoriasis. So these are the points with the help of which you can differentiate all these conditions. So this is the next question. A patient presents with multiple painful blisters. Blisters are vesicles or bullae on the trunk as shown in the image. And in the image, if you observe carefully, how are these blisters present? They are present over erythematous base and they are following a single dermatome. So if you get a patient clinically presenting with painful vesicles or bullae which are following a single dermatome, always you should think about herpes zoster. Okay, so herpes zoster is caused by varicella zoster virus, which is human herpes virus type 3. You might be wondering, even chickenpox is also produced by the same virus. Then how to differentiate between both of them? Please remember, chickenpox, which is also called as varicella, this is going to manifest with fluid filled lesions affecting children, where fluid filled lesions will be present over the trunk. It will not follow, the lesions will not follow a single dermatome, the lesions will be present over the trunk. And not only that, we can see characteristic polymorphic and pleomorphic lesions. What does pleomorphism mean? That initially there will be macules which will convert into papules, which will again convert into pustules, and finally there is going to be crusting. So this is called as pleomorphism and it is characteristic of chickenpox. And it is called polymorphic because the lesions over the child at a given point of time, there will be so many types of lesions. There will be vesicles, there will be crust, there will be papules, there will be macules. So this is the reason why they are described as polymorphic and pleomorphic. Okay, so in measles, please remember the lesions are going to be maculopapular lesions, and along with that in the history there is going to be a mention of cough coryza, and also there can be a mention about Koplik's spots which are pathognomonic for measles, Koplik spots. And SCID is severe combined immunodeficiency disorder, where there is a defect in the B and T lymphocytes, because of which there can be possibility of many kinds of opportunistic infection. But this is not going to specifically show the painful blisters in a single dermatomal fashion. So that is the reason why SCID is not the answer, and answer here is herpes zoster, which is also called as, there is one more name for this, you must know, it is shingles. Okay, so this is about this shingles. So this is the next question. A 3-month-old baby is presenting with ptosis of the eye and the following presentation. So in the image, what you are able to see, you are able to see there is a red raised plaque. A red raised plaque is present over the left upper eyelid, because of which there is ptosis. So among the given options, if you look carefully, port wine stain and salmon patches, these two are not going to present with raised skin lesions, but they are going to manifest with flat lesions, flat erythematous lesions. So these two can be ruled out. So in a exam, always remember, ruling out of the options is also very, very important. You have to practice many questions so that you are going to hone the skills of ruling out of the options. Okay, and here please remember, cavernous hemangioma and capillary hemangioma, both of these are vascular tumors, whereas cavernous hemangioma is precisely mainly going to target and involve the internal organs. Of course, it can also affect the skin, but in the skin involvement, the lesions are going to be very much raised, and also they are blue colored. So these are the points which will be in favor of cavernous hemangioma, which are not given in this question. So the answer here is going to be capillary hemangioma. So now let us look at each of these options and how they look clinically. So the first one is port wine stain. So port wine stain is going to be seen since birth. And if you look at the lesions, they are basically capillary malformations, and they are going to be present unilaterally. As you can see in this image, this is a port wine stain, where you are able to see this unilateral erythematous patch which is present. And if you look at this person, the same child, after growing up, you are able to see this port wine stain which is persisting throughout the life. It is going to typically persist throughout the life. The port wine stain is going to persist throughout the life. And if you take a glass slide and if you try to press this lesion, it will not blanch. It is a non-blanchable skin lesion. Okay, port wine stain, and it is a capillary malformation. I hope you do remember in your pediatric classes you might have heard about Sturge-Weber syndrome or Sturge-Weber syndrome. It is associated with port wine stain. The next one is salmon patch. Or nevus simplex. This is also seen since birth, and this is blanchable. Why is it blanchable? Because basically it is just a telangiectasia. It is a capillary telangiectasia which can be seen over the skin, and this has various fancy names. If the salmon patches are present over the glabella, they are called as angel's kisses, and if they are present over the nape of the neck, they are called as stork bites. So here you are able to see a stork bite which is present over the nape of the neck, which is nothing but the other name for the salmon patch, or it is also called as nevus simplex. So the next one I have already told you, this is cavernous hemangioma, which is going to be present deeper in the skin and involving the organs. And this is going to be blue in color, and this can also persist throughout the life. So here you are able to see the cavernous hemangioma which is affecting the skin, and you are able to see that the bluish hue present, and also you can see that it is more of a growth present in the deeper structures of the skin, because of which you are able to see that it is very much raised lesion when compared to the capillary hemangioma which was given in the question. Okay, so that was about the cavernous hemangioma. The next, coming to capillary hemangioma, it is not going to be seen since birth. As in the question it was mentioned, a 3-month-old baby is presenting, so it is not mentioned since birth because capillary hemangioma is not going to be seen from the birth. And you can see that it is a vascular tumor, as you are able to see from the name itself, cavernous and capillary hemangioma. Oma is there. Oma is nothing but a tumor. It could be benign or malignant. Here it is a vascular tumor. Okay, so this is how you can differentiate these conditions, and you can see this capillary hemangioma, it can obstruct the vision. And not only that, if it is present in the airway, it can also obstruct and cause difficulties in the breathing. So whenever a child is having the lesions of capillary hemangioma or infantile hemangioma, it is also called as infantile hemangioma. That could be the other name which can be mentioned in the question. So if the child is having symptoms due to this, then we can use beta blockers as the treatment modality. Beta blockers, which is propranolol, which is routinely used. Propranolol can be used, as in this case it is causing difficulty in the vision. So if at all need arises, we can use this medication in these children. So this is the next question. A 25-year-old female is presenting with special lesions. So this is what is the examiner already mentioned in the question, special lesions. And you are able to see that this is the image where you are able to see black dots. Some black dots are present over the cheeks. And these black dots, if you remember, we have discussed in the basics of the skin, these special lesions which were one burrows, two target lesions, and the third one was comedones. Yes, the answer here is option A, comedones. So you are able to see black colored dots present over the skin surface. So this is a case of acne vulgaris, which is due to the obstruction of the pilosebaceous unit with a keratin plug. So if this keratin plug gets oxidized, then we are going to see a black colored lesion, which are called as open comedones or blackheads in the layman terms. And if they are not exposed to the environmental oxygen, then we are going to see a white colored lesion, which is called as a closed comedo. It is also called as a whitehead. So these comedones are the special lesions which are seen in the acne. They are the special lesions which can be seen in the cases of acne. The other lesions, pustules and papules, can also be seen in acne, but they are not a characteristic of acne. They can be seen in other conditions as well. So the answer is comedones here. This is the next question. A patient presenting with itchy lesions on the wrist and involvement of the oral mucosa. On examination, following findings were noted, and you are able to see that there are plain topped, purple papules are there, plaques are there. So all these features are pointing towards a diagnosis of lichen planus, where we are going to see mainly the P's. What are those P's? So as I have already told you, plain topped, purple, itchy is pruritic. So another P, papules and plaques. And also, if you remember, the important nail change, the most characteristic nail change which we can see is pterygium. So this is another P. And where are the lesions seen? Wrist. Wrist is a flexor. So instead of flexor, remember it as a plexor. So this is another P. So whenever you see this kind of a question discussing about mostly P's, the diagnosis which you must think about is lichen planus. Very, very important. And also you have a clue that oral mucosa is involved. Please remember, even oral mucosa can also have involvement in the lichen planus, where we can see white lacy plaques. So white lacy plaques can be seen in the oral mucosa. Even genital mucosa can also be affected. Okay, so you might be wondering, what is this lichen nitidus? Just remember, clinically lichen nitidus is going to manifest mostly in children. And how does it look like clinically? There will be skin colored shiny papules, as you are able to see, tiny skin colored to shiny papules can be noted. But the most important site which the examiner loves to give you is over the genital. So if a child is presenting with skin colored to shiny tiny papules over the genitals, then you must think about lichen nitidus. Okay, so this is the last question. So a elderly 50-year-old female, known case of ovarian cancer, coming with a difficulty in activities like climbing stairs, getting up from the chair, and combing hair. So all these are pointing towards basically proximal muscle weakness. Proximal muscle weakness, the following characteristic sign was found on examination, and what you are able to see over the face, there is erythema present over the cheeks, erythema present over the nose, and you are also able to see erythema present over the eyelids. So if you see this kind of a clinical picture with the proximal muscle weakness given as a clue in the question, you must think about dermatomyositis. So you can see the disease name itself is having skin as well as myositis, muscle involvement. So please remember, in dermatomyositis, this erythema which you can see is called as heliotrope rash. But apart from the malar rash, which is a butterfly rash which you are able to see here, and heliotrope rash, dermatomyositis can have various other named signs and presentations. What are those? Gautrans papules, Gautrans sign. We can also see shawl sign. We can also see V sign. So in shawl sign, there is going to be violaceous macular erythema present over the shoulders, and in the V sign, we are going to see violaceous macular erythema present over the anterior chest. In Gautrans sign, violaceous macular erythema will be present over the knuckles, and in the Gautrans papules, along with the violaceous macular erythema, papules will be present over the knuckles. Okay, so these are all the named manifestations which we can see in dermatomyositis. So why is this history of ovarian malignancy given? Please remember, dermatomyositis is a connective tissue disorder which can have a underlying malignancy, which can be associated with the underlying malignancy. So that is the reason why it is given. So you might be wondering why it cannot be SLE, because malar rash can be seen in SLE also. But please remember, if it has to be SLE, this muscle weakness point should not be given in the question, but instead there can be mention of oral ulcers which are characteristically painless, and there can be involvement of the joint pains can be given in the question. Joint pains, history of fever. If they are all mentioned, then it would have been systemic lupus erythematosus. But otherwise, malar rash can also be seen in dermatomyositis, And the difference in malar rash in these two conditions is systemic lupus erythematosus, malar rash is going to spare the nasolabial folds. Spares the nasolabial folds, okay. Whereas in dermatomyositis, the nasolabial folds can also have this malar rash. Nasolabial folds can also have this malar rash or malar erythema. So systemic sclerosis, I hope you all have read this in your medicine very detailed way. So this is a scleroderma. This is nothing but the scleroderma where you are going to see thickening of the skin. So in this, what will be the skin manifestations? The thickening of the skin can be there, along with which there can be microstomia, and also salt and pepper pigmentation can also be there. So these are all the manifestations of systemic sclerosis. And Cushing syndrome is basically because of high levels of the cortisol hormone, cortisol, and there is going to be weight gain and purple striae, which are nothing but the stretch marks which you are able to see. So these will be the manifestations of Cushing